So I'm Karen Levers, Programme Lead within South Yorkshire and Basset Law Cancer Alliance, and will be the host for today's session. So the session this morning will be on See the Signs Cancer Decision Support System to enable early identification and referral of patients at risk of cancer within primary care. This will be covered by a presentation from Dr. Miles Payling, followed by a Q&A session. So the webinars within this series will highlight research, innovation best practice across the South Yorkshire region, and will run weekly from September 25 to January 26, with each month focusing on the following themes. So we have cancer, children and young people, prevention, workforce and economy. In line with the 10-year health plan, we want to try and maintain the energy around innovation as a national priority. Innovation drives progress, enhances problem solving and fosters growth, which will forever support our health and care industry. We hope you'll feel inspired by our speaker today, gain insight into research and innovation delivery, and can take away tips to use in your local workplace or system. I'll now pass you over to our speaker, Dr. Miles Payling, to talk to you more about the See the Signs Cancer Decision Support System.
Oh, thank you so much, Karen, and a lot to live up to from that introduction, so thank you. I'm just going to share my screen. Karen, can you just confirm that you can see the slides?
Yes, yeah, I can't see. That's it. Yep, brilliant.
Perfect. So as Karen said, my name is Miles Payling. I'm one of the co-founders and I'm the Chief Scientific Officer at See the Signs. And my background is I'm a hospital clinician by background, worked in the NHS for many years, then worked at the British Medical Journal for several years, translating research into clinical practice, and then co-founded See the Signs about 8 years ago. And we've been operating in South Yorkshire and Basset Law for a number of years now. And in this presentation, I'm going to really try to distill cancer down to the numbers and why interception and early interception really does matter. Hopefully there'll be some statistics that you're unfamiliar with. Some of them I'm sure you are familiar with. And then I'll show you how See the Signs works and then some of the research that we've done with See the Signs so far. So first of all, I'm sure many people are aware of this statistic that 1 in 2 people will be diagnosed with cancer at some point in their lifetime. If you catch it early, 90% of patients on average survive to 5 years or more. But if you catch it late, only 30% will survive to 5 years, even with the best treatments. And obviously there are a lot worse cancers out there as well, like ovarian and pancreatic cancer, which can have much worse outcomes in late stage. In terms of cancer in the UK, sometimes it's thought of that cancer is, an old illness, but actually 40% of patients are diagnosed under the age of 65. So it is becoming a younger illness. And that's also highlighted with the rate of acceleration. So in patients between the ages of 25 and 49 in the last 25 years, they've increased by 24%. And that's compared to over 75s, which is less than 10%. So it really is accelerating in that young age group. The other aspect is that the early stage detection across England has been fairly static over the last 10 years at about 54%, and then it's jumped by about 4%. And I think the Darcy report mainly put that down to the lung screening programme, the targeted lung health check. So a lot of work to do to get to the 75% standard that was intended about 8 years ago now, or 7 years ago, to get to 75% by 2028. The other thing about early and late stage cancer is that the treatment costs alone for late stage cancer is much more expensive than early stage. It's about double the cost. And for every case that you can move early, you can save about £6,000 to the NHS just in the treatment costs. That's not including any of the sort of admission costs or any of the extra costs that goes together with late stage diagnosis. And then the other thing to bear in mind is that most cancer presents symptomatically. So 95% present symptomatically. So all clinicians have a vested interest in trying to identify these patients when they do present with symptoms at the earliest possible time. And what I want to do is just take you through the journey of a typical cancer patient from early diagnosis all the way to late stage. So patients often start with asymptomatic cancer, that first start of a few cells dividing that are cancerous. And that's what screening programs are designed for. And at the moment, we detect about 5% of patients with cancer through screening programs, and 95% of them are early stage. But as you'll be familiar with, we only have about 4 screening programs, breast, bowel, cervical, and lung. Prostate sometimes is included in there, but it's not really a screening program as it stands. That leaves the majority of cancers in the symptomatic stage that we need to identify. And the first start for patients is they start suffering with their symptoms, but they suffer in silence. And they need to overcome a threshold to actually go and see someone about it. And there are many reasons why patients meet this threshold, but the sort of 5 main ones that have sort of been highlighted by the research are: 1, interference with life, so they can't do something that they previously could do, so like going to work, for example. The second one sounds a bit fancy, a temporalizing symptom duration, but essentially that means where patients essentially safety net themselves. I'm going to go and see the doctor if this hasn't improved in the next 2 weeks or next 3 days. Interpersonal crisis tends to be related to mental health problems, so not necessarily related here. Sanctioning is where someone has told them they should go and see the doctor. So that could be a friend, a family member. It could be seeing an advert on TV that sort of says your symptoms need to go and see the doctor, etc. And then finally, the symptoms become intolerable. So it tends to be related to things like pain, change in bowel habit, etc. Then the patient finally attends their GP practice, and this is where diagnosis becomes extremely challenging. Because cancer is a cradle-to-grave disease, it affects all age groups, it affects all genders, and it is the great mimicker of all other diseases. So it can present in virtually every conceivable way as every other disease, and most of the other diseases are probably more common in that individual case than cancer is. So it becomes very challenging to identify these patients. And added to that, a GP has only 10 minutes to see the patient, and they don't see that many. So they'll only see 8 new cases per year, and that may be out of about 400 patients that they see a month. So it really is trying to find a needle in a haystack. And that's reflected in the data. So 45% of patients are missed on their first appointment. So that gives us a massive opportunity to identify these patients, the 55%, the 45% that are missed at the moment. But added to that is that 20% of patients will see their GP 3 times or more before they're identified at risk of cancer. And this is even worse in ethnic minority populations. So other great opportunities that we can do to try and identify them at that earlier stage. The next stage of that is the urgent suspected cancer referral and getting them into secondary care for investigation. The 28-day diagnostic standard, so that's within 28 days, patients should either be diagnosed or excluded from cancer in that time frame. The current target is 75%, so we are just about making that, but the issue with that is that it should really be about 85% by now, but NHS England has delayed that until March, so it's right at the end of the financial year rather than at the beginning of the financial year, because it's extraordinarily challenging. And about 3.5 million urgent suspected cancer referrals are done each year in the NHS, so it's not a small volume problem, it's a very large volume problem. But key to early stage versus late stage is when they start treatment after suspecting cancer, and at the moment we're only reaching about 71%. And that's the target is 85%. So we're way below that standard, and that's really only when you can start to halt the spread of cancer is once you start treating it. The worst case scenario is patients being diagnosed in A&E. About 19% of patients are diagnosed there. They tend to be late stage, tend to have at least one organ failure by that time, and that leads to survival rates of less than 40% at 1 year. But the key here is that 2/3 of those patients that turn up in A&E have seen their GP within the previous 12 months with accelerating symptoms. So another opportunity to identify them. And why all this sort of matters is because it's building time into the diagnostic journey, and that if we can intercept, we can decrease mortality. And the key stat to remember here is, on average, if you wait 1 month, or for every month that you wait, the risk of mortality increases by about 10%. So you can see that multiple appointments, multiple stages, even in the built-in 28-day standards, the 62-day standard, we are building in mortality. So it's important and imperative that we try to push patients down to the asymptomatic to primary care stage. So See the Signs his mission is really about giving everyone the chance to survive their cancer through early diagnosis. And we have 3 main products that supports this. So we have a point of care decision support, which I'll show you in a moment, which essentially is integrated into the electronic healthcare record in primary care and allows you to risk assess, refer, and safety net patients at risk of cancer. We also have now a patient assessments tool, which allows patients to risk assess themselves on specific pathways. And I'll show you a bit more about that in a moment. And that allows them to triage either into screening programs, back to primary care, or directly into secondary care. Most of it is directly into secondary care investigation pathways there. And then finally, we have population-based case finding, where we can scan EHR records and identify patients that may be eligible for screening programs or direct to investigation from there. If I just show you how those products work again, just so it highlights to you where they operate. So that point of care decision support is within the primary care in GP practices, and it can be used by all healthcare professionals within primary care. We have patient assessments. That's trying to overcome that threshold for patients to come and see their GP, but it can also direct them into secondary care. And I didn't mention this before, but as part of patients' assessments, we have a provider dashboard, which essentially allows secondary care to track those patients into their own pathways, and that may be investigation first, into consultation with a consultant before diagnosis or exclusion. And then case finding, as I mentioned, operates across asymptomatic to the GP practice to identify potential patients that may be at risk of cancer or that would benefit from screening programs, like identifying patients with a targeted lung health check. So just to show you how the point of care decision support system works, if you're unfamiliar, so we have a toolbar that sits on top of the electronic health record. It works with System 1 and EMIS in the same way. You can go directly to risk assess. You can directly refer as well. You can risk assess via system or search. System is just where we collect the symptoms into system-based decision support systems. And you can simply tick off the risk factors, symptom signs, and test results that are present for the patient. We then calculate very quickly, and this is all in real time, if a patient's at risk of cancer. We cross-reference that against all other cancers to make sure we don't miss anything. If they have a referral, we bring that referral through and pre-populate everything for that. We also have mandatory fields to make sure it doesn't bounce back to you. And there were patient information leaflets there that can be sent directly to the patient. And then that's all saved back into the medical record, coded, so you don't have to duplicate the consultation either. So really supporting being able to rapidly risk assess a patient in those very short minutes that you have with a patient. The other part of the system is the safety netting dashboard. We have an inbox feature, so when a referral is generated, your administrators can pick up the referral and book that onto ERS. And then we also have this the dashboard, which essentially tracks all patients on cancer pathways and brings in all that information. And you'll be able to open records up to see how they presented and what they're planned for. You can record the outcome manually. We also have a lot of automation of this now. So if you are in a practice that has See the Signs in System 1, you can email me afterwards and we can get that set up for you. We have a fit dashboard to track the IIF, which has the sort of financial incentives to it. And we also have a Cancer Confirm board, which allows you to record your cancer care reviews through that and perform the cancer care reviews directly through See the Signs. A new feature that's coming in the next couple of months or so is Jess's rule. You may have heard about this over the last sort of 24 hours. Essentially, if you're unfamiliar, Jess Brady was a young woman about 30 who was diagnosed with very late stage cancer. She had been to see her GP, I think, about 19 times before being identified at risk. And there were many features that were challenging here. She saw lots of different clinicians, which makes it even harder to identify cancer, particularly when it's a patient coming back numerous times. But essentially, the health secretary and the Royal College of GPs, along with Jess's family, have pushed for this. If a patient comes back with 3 times with similar symptoms, they should be considered whether further tests or further referrals is necessary. And so what we've done here is if you open up a patient and they've attended, this is their 3rd consultation in 3 months, we automatically prompt you. We pull through all the risk factors, symptoms, signs that are coded into the medical record into our system. And I'll play that again because it's very, very quick. But we pull that into our system. We show it to you in this Learn More feature so you can see what symptoms they presented with. We pull it through onto our risk assessment platform, show you what they're at risk of, and then you can action that straight away and save it. And if there is a referral, you'll be able to generate the referral at the same time. So really sort of accelerating that process, but also not having the issue where if a patient's seen, 2 other clinicians and you're the 3rd one, you're unaware of that sort of 3rd consultation, will alert you to that straight away. The other part that I mentioned was about patient assessments. So we also now have some services across the country for patients to self-assess themselves. So there are 3 or 4 main pathways that we have operational at the moment, which is endometrial for postmenopausal bleeding. We have one for lung symptoms and bowel symptoms, and there's some new ones coming in breast genetics and gastric and pancreatic cancer. And it essentially allows us we can use case finding to identify cohorts that may be at risk. We send them out a patient assessment to complete, and it can be done on mobile or website. And then it tracks them all the way through, and we can funnel that into a referral form as a GP would complete anyway, and provide that directly into secondary care so that they can either triage or they can be triaged direct to test. So with bowel, we have a straight to fit test, and endometrial, we have a triage first before ultrasound. Now, just to talk to you about the impact of See the Signs, because it's really important from our side. As I mentioned, our mission is to give everyone the chance to survive their cancer, and that means we want to be as close to proving that as possible. And the point of care decision support system has been in the NHS the longest, so that's been in place for around 7 years, integrated for the last 5 years. And what's really encouraging is the data really supports how good it can be. So in terms of the accuracy in predicting the tumour origin, so do we get the cancer right when we say a patient's at risk of cancer? We get that right in 9 out of 10 times, 94%. Do we see more patients being diagnosed in primary care as opposed to those other parts of the system later on, particularly from A&E? Yes, we do. We see it at 8 to 12% increase. And usually the NHS as a whole sees that move by less than 1% a year. So really like dramatic changes that we see in primary care detection. In some pathways, we've seen significant improvements in time to diagnosis, so anywhere between 20 and 50% by optimizing that pathway. As I mentioned about referral forms also contain mandatory fields, so it's not bouncing back to primary care, it's getting all the information there on day one. We've diagnosed patients all the way from birth all the way up to 94. I'm sure it's probably older now, but that's the last time I looked. And then we have a 99% sensitivity. So if a patient has cancer, we incredibly rarely miss it. And it's much stronger than the, as I mentioned before, the number of patients that are missed is about 45%. So in primary care at the moment on their first appointment. We've actually, this slide is is a few months old now. We've now helped to diagnose over 65,000 patients within the NHS. And this just goes to show you that we diagnose all types of cancer. This is broken down into the broad systems. We've looked at the individual types, and there are over 110 different types of cancer, but it's over 99% of cancer incidence that we're able to detect through our system platform. In terms of some of the data that we've seen locally in South Yorkshire and Basset Law, this was a comparative study where we looked at practices using See the Signs versus not using See the Signs after See the Signs was immediately implemented. And we particularly looked at practices that had a high deprivation. And it showed that we increased cancer detection, so that the number of patients that are identified with cancer through a primary care pathway rather than elsewhere in the system, and we significantly improved that compared to those matched controls. Similarly, in other areas, we see the same thing. This is just to show you one other area where in Bury, which is in Manchester, we saw cancer detection improve by, in this case, 12.9% in a 2-year period. So it increases, it's sustained. But the other thing they looked at here was they audited the stage of diagnosis, and they showed that the stage of early stage detection went from about 56, 57% to 60% in that relatively short period of time. And as I mentioned before, stage shift has been relatively unaffected over the last sort of 10 years, apart from targeted lung health checks. The other thing that the risk assessment part of the system does is it helps to identify patients that don't need urgent suspected cancer referrals and funneling those patients out, which can really help the system to cope because of that high volume, as I mentioned before. So within our system, we triage about 21% of patients away from urgent suspected cancer pathways. About 10% or so don't require any cancer investigation at all. And the remaining 10% are sort of funneled between routine appointments and direct access tests. And because we configure the system to local guidance, local available pathways, they're all pathways that are available to you and set to the criteria that will be accepted for those pathways as well. And what that results in is that the cancer conversion rate for See the Signs is quite a bit higher. And the cancer conversion rate for NHS England average is about 6%. Ours is about 7.3%. That sounds like a very small number, but actually that's 20% higher. And it means that if you were to take that 3.5 million referrals, you'd need 20% less to diagnose the exact same number of cancers. Just rushing through to the end because I appreciate I'm a bit over time, but just to say we've also looked at stage of diagnosis. Staging data is a bit more tricky for us to access because it's not well recorded in primary care, but we looked at this with Somerset and showed that ovarian cancer, which is very stagnantly low, we increased that by 53%, and this was looking pre-COVID to 24. So over that 5-year period, we saw a dramatic increase there. We also saw a dramatic increase in pancreatic cancer. That's not really changed for 60 years at about 12% early stage. We saw it at 30%, so really dramatic. And then finally, on the patient assessments pathway, the postmenopausal bleeding endometrial pathway was the first one to go live. And what was really interesting here is we saw that that days to diagnosis, the faster diagnosis standard went from 48 days down to 22, and we got it up to 84%. And through that pathway, 19 women were diagnosed with cancer, and all within the 62-day standard. So, sorry, rushing towards the end, but hopefully that's given you a flavour of See the Signs, and hopefully a bit more about why cancer identification in primary care is so important.
Thank you, Miles, for that really interesting and insightful presentation, particularly all the stats that you've been able to share, how the system can support the patient journey, and then obviously all the elements of what the See the Signs support system can offer. So thank you, thanks again. So I'll now hand over to Health Innovation colleagues who will support with the Q&A section.
So to begin, Miles, we know that you've been on quite a bit of journey to kind of get See the Signs to where it is now. What would you say have been the biggest challenges when it's come to implementation, especially within kind of primary care?
I think we've had an awful lot of support from primary care and from cancer alliances across the country, and particularly in South Yorkshire, really supportive of the journey. I think that one of the biggest challenges in primary care is time. And as I mentioned, they've only got 10 minutes to see a patient, but also everything is kind of pressured onto primary care in terms of, vaccinations, everything, if you think about it, drives back to primary care. That's where, the new long-term plan also sets primary care as being the sort of bastion. And I think that pressure, not sort of matched with funding, they deal with 90% of the activity of healthcare, but they receive 10% of the budget. It also means that there is enormous pressure, and when you're launching sort of a new system and trying to find time to train and things like that, I think that's probably the hardest thing. But as I said, GPs and practices across the country have been incredibly supportive of it. Sometimes there are worse times of the year to deploy See the Signs, so like winter times, particularly where the winter pressures come. But as I said, I think that's probably the major challenge. But that's what we've always been like there to design, is to try and make sure that whatever we're designing can fit in and to accelerate what GPs are already doing as a great job. And to support them in that very difficult process of identifying them earlier, because there's not really any sort of toolkit that they have to identify patients at that really early stage, apart from clinical acumen. And being a doctor myself, you learn by experiential learning. So you learn by seeing, doing, teaching. That's the mantra of when you do a procedure is see one, do one, teach one. It's also the mantra of sort of how you learn. If I ask everyone in this room to think about a patient with cancer, you're probably thinking of either a personal experience, or you're thinking of a patient that's older, probably has grey hair, probably looks like they've lost a huge amount of weight. Whereas actually, the patients that are the group that's growing the most are the patients that are in the 25 to 45, 49-year-old category. You don't really want them to have lost a lot of weight before they're diagnosed. Weight loss can be quite a late symptom in many cancers. So that experiential learning sort of does an injustice for cancer just because it's so infrequent in primary care. It's frequent in sort of over a lifetime, but it's infrequent just from a day-to-day job perspective. Sorry, long answer.
No, a great answer. It just sounds like, I guess, something like this is very fit for purpose, and it sounds like there's a lot of kind of tailoring and support, especially to kind of certain practices who may have challenges in those areas, whether it's funding, whether it's kind of resource and timing. It seems like this really streamlines and supports the future of, I guess, helping people identify what cancers people do have. I guess as a follow-up question from that, what would you say would be kind of the key takeaway kind of bits for people here today if, let's say, they work in a practice but they've not yet started using See the Signs to support?
I would say that we are here to support you. So, you know, we have colleagues that are there to help support your practice, train your practice. We have clinical training, we have administrator related training so that your admin team can get up to speed with tracking those patients on that safety netting dashboard. In terms of sort of using the platform, hopefully, as I showed you, we've tried to design it as intuitively as possible so that you can see what, you know, you can almost have zero training and get on with it and work out how to risk assess a patient just by, you know, how you think about diagnosing a patient. So thinking in collections of symptoms in terms of that system approach that I showed you, getting directly into the referral forms. As I said, some of the other systems that you may have access to, excuse me, may have referral forms, but they may not have the mandatory fields to make sure those referral forms don't come back with like questions like you haven't done X or Y before I receive it. And that really does help streamline for secondary care to make sure that patients are fit enough, or that when they're being triaged straight to test, that they're getting on the right pathway and not sort of bouncing back to you in primary care saying they can't have any investigations because they're, you know, they're mobile or they have this condition which prevents them from having X, Y, and Z. So I think that's what I'd really say to anyone that's not using it. And as I said, we're constantly providing new features as well. That Jess's rule that I showed you earlier, that's coming in the next couple of months, that should really help to sort of streamline that challenge also of knowing how do you know if someone's attended 3 times or more. You have to look through their past records and look to 3 consultations, look at whether it's been in the last 3 months, that kind of thing. We're going to do that for you. So I think those aspects are really going to help support you in your journey to identify these cases. And what I think is often missed is the psychological effect, not just to the patient, but to doctors when they miss cancer. Because when you miss cancer and it's been, you know, I could have identified it 6 months ago, it does take a toll. You know, everyone's human at the end of the day. Everyone makes mistakes. As I said, about 45% will miss it on the first time. It can be identified, and that's the key thing, is like with these systems like See the Signs, it can really help to support you in identifying those cases and not having those challenging cases that you may have missed in the past.
Thanks, Miles. I think that 45% really shocked me today, and I'm sure it will have done the same for others. And I think it is surprising, that number, but I think it really emphasises the need for innovative systems like this. And it's there as an add-on, it's not instead of, you know, it's
Exactly.
a support tool, and it's brilliant. I think you might have answered the next question. So the next question is, what's next for See the Signs? And I know you kind of mentioned Jess's role, but is there anything else on the cards that's coming up next?
I'm a co-founder. I can tell you about it. I'm probably meant to not tell you about it, but there are things with genetics. So looking at how we can support patients that may be at genetic risk of cancer. So taking family histories accurately, allowing patients to take their own family history, so that general practice isn't sort of gummed up by that process. We're looking at things like some areas have follow-up for PSA monitoring in prostate cancer. So many patients with prostate cancer are on sort of watch and wait pathways, and even those patients that have had treatment are often on PSA monitoring, and often that's sort of discharged back to primary care, and then it's very challenging to monitor these patients. So we're looking at how we can help support monitoring of PSA tests within our platform automatically, so we can send out messages to the patient when they need to book blood tests, and then we'll flag it to you if the results are elevated to refer back. And then a lot more work on passive risk assessment. So we're looking really hard to try and help reduce that barrier of I need to be thinking about cancer to we've already thought about it and we'll just give you the nudge. And making sure that nudge isn't like some of the historic systems that you may have seen where it nudges you on virtually every patient and then it gets frustrating. So that's what we're really focusing on for the next sort of 12 months or so.
Thank you, Miles. That sounds brilliant. You all heard it here first.
Exactly, yeah.
Thanks, Lisa. I think that's all the Q&As that we've got so far. If anyone does have anything last minute, please do stick it in the Q&A or the chat box so we can pick it up. Alternatively, you can drop us a line if you've got any questions for Miles after. As we mentioned before, we will be posting this on our website too, but I will then leave it to Karen to follow up.
Thank you. So thank you for completing the polls. So also thank you for attending today, particularly Miles for the presentation. So it's been a really enjoyable session. So just to note, a reminder that all of our bite-sized webinars have been recorded, will be uploaded to the South Yorkshire Innovation Hub website for you to share with colleagues, and also watch back if you wish. The webinar is part of a whole South Yorkshire Innovation Hub bite-sized series, and to book on to future sessions, please follow the link in the chat. So thanks again, everybody, and obviously enjoy the rest of your day today.
Thanks, everyone.
Thank you.